So first of all, thank you very much for this outstanding scientific program and also for the hospitality. You are really great, ex-Mexican, and as Italian, I feel like in my house, believe to me. It's not usually for an Italian. So in the next half an hour, I will provide an overview of the new treatment options for ER-positive and HER2-positive metastatic breast cancer. So this is the outline of my presentation. I will provide data on PI3 kinase and mTOR inhibitors, CDK4/6 inhibitors, a summary and the comparison of all trials, fibroblast growth factor receptor inhibitors, epigenetics, that I believe is an important field, and finally, new drugs in HER2-positive breast cancer. This is, I believe, a very nice slide. In 1 hour from now, there will be a great speaker that is Kent Osborne. He dedicated all life to understand the mechanism of resistance in ER-positive disease. And I must confess that many of the new options that we have today are based on the discoveries of Kent Osborne. So this is the estrogen receptor that usually binds to estrogen. And once you give an endocrine therapy, you can stop the transcription and the proliferation of the cells. But sometimes you have a primary resistance, and so a specific mutation of the binding ligand of estrogen receptor, and this specific mutation is ESR1 mutation, very rare as a de novo mutation. If you give a SERD, you can overcome this type of resistance. So if you progress to tamoxifen or to aromatase inhibitors, you give fulvestrant, and you can overcome this type of resistance. But you may have a secondary resistance that is related to the upregulation of new pathways that are not strictly related to the binding of estrogen to estrogen receptor. And that's why many new agents that have been developed are targeting these alternative signalings, which is MET, epidermal growth factor receptor and HER2, fibroblast growth factor receptor, insulin growth factor receptor, and all the downstream pathways that usually are phosphorylated and that increase proliferation, cell survival, and invasion. That's why all these new agents that are under development may target the downstream pathways. Don't forget that many clinical trials and many preclinical data have been also produced in the targeting of the cellular membrane receptor. If you remember the trial combining endocrine therapy plus epidermal growth factor receptor tyrosine kinase inhibitors, including also trial with insulin growth factor receptor inhibitors. But the only one that reached clinical practice are mTOR and CDK4/6 inhibitors. And these are all the agents that actually are under development. We have here the CDK4/6 inhibitors and the PI3 kinase inhibitors, two different classes, the pan-tyrosine kinase inhibitors and the alpha-selective PI3 kinase tyrosine kinase inhibitors. Let's start now from the primary resistance to the secondary resistance to provide some data, some clinical data. This is the estrogen receptor ligand binding domain point mutation. What's about the incidence? It's quite rare in primary breast cancer, so less than 2%. In patients that are de novo metastatic, the incidence is around 9%. But in patients progressing to aromatase inhibitors, you can reach also 20% of incidence. One way to overcome this type of resistance is giving fulvestrant, a drug like a SERD. And I like to present this data because this is a very important study, I believe. Look at the inclusion criteria. These are postmenopausal women with ER-positive disease who never received an adjuvant treatment or who never received an hormonal treatment for breast cancer. So these are patients endocrine naive. And so we assume that they are really endocrine sensitive. And look at the final data. So if you compare fulvestrant versus an aromatase inhibitor, you can reach in patients with bone-only disease a progression-free survival of 22.3 months. So the message is that in patients endocrine sensitive, endocrine therapy alone is still an option. If you have patients de novo metastatic who never received an endocrine therapy, with the low probability of having a mutation of ESR1, endocrine therapy alone is an excellent choice. Which are the new SERDs under development? I will mention just LSZ102, because in December in San Antonio, you will see the first data on this new SERD. This is a SERD designed specifically to overcome the resistance to ESR1. It's an oral SERD, and respect to the other SERDs does not give diarrhea, so there is less toxicity. It's a very promising agent. We completed a phase 1 dose escalation study, achieving 40% response rate in many patients who progressed to a previous endocrine therapy. And now there is an expansion cohort randomized to SERD plus a PI3 kinase, that is alpelisib, and SERD plus a CDK4/6 inhibitor, that is ribociclib. What's about the mTOR MPI3 kinase pathway? This is biological a secondary resistance, so it's the upregulation of pathways in order to block, to increase the cell proliferation. Here we have different classes of agents: the pan-PI3 kinase inhibitors, buparlisib, pictilizib, XL147, and the alpha-selective PI3 kinase inhibitors like alpelisib, tazelisib, and the PI3 kinase beta-selective of GlaxoSmithKline. It's quite important to understand that these agents are potentially active, but they are also toxic. So it's not so easy, the management of this type of agents. Let's start with the mTOR inhibitor. We don't have to forget that we have also everolimus for patients progressing to endocrine therapy. This is the Bolero trial. Patients who had recurrence during or within 12 months after the end of adjuvant treatment. So these are patients that are resistant. And they have been randomized to everolimus plus exemestane versus exemestane plus placebo, with an increase of progression-free survival. What's about the PI3 kinase inhibitors? This is the BEL-2 trial. It's exactly the same setting of the Bolero trial. So patients progressing to an aromatase inhibitors or within 12 months after the end of the adjuvant treatment. And here the combination is fulvestrant plus buparlisib versus fulvestrant plus placebo. There is a marginal benefit in terms of progression-free survival, and the benefit is more in patients with the ctDNA PI3 kinase mutation. So it seems that these patients may derive more benefit. In the BEL-3 trial have been included patients progressing after an mTOR inhibitor. So exactly the patients progressing to the setting of the Bolero trial. And here, after a progression to everolimus, patients have been randomized to buparlisib plus fulvestrant and placebo fulvestrant. Median progression-free survival 3.9 months. And a lot of toxicities. Increase of ALT and AST, hyperglycemia, and nausea. So the message is that pan-PI3 kinase inhibitors can increase progression-free survival with increasing also toxicity. So I don't believe that no one of these agents will arrive in clinical practice. Which are the trials ongoing? We have two trials. One is the SOLAR-1, fulvestrant plus alpelisib, and the second one is the SandPiper, fulvestrant plus tazelisib. Both are alpha-selective PI3 kinase inhibitors. But what's about these alpha-selective inhibitors? This is the RE trial presented during ESMO 2017. It's a neoadjuvant trial comparing tazelicib plus letrozole versus letrozole plus placebo. And the primary endpoint of this study was the clinical response assessed by MRI. And the secondary endpoint was also the PCR. Look at the data. In terms of clinical response, the addition of a PI3 kinase selective inhibitors may increase response rate from 38% to 56%, increasing also breast conservative surgery. But if you move to the pathological complete response rate, it's quite low, 1.4%. This is the first prospective randomized trial in early breast cancer with a PI3 kinase inhibitor. RE met its primary endpoint, but increase in overall response rate should be balanced with more toxicity. Diarrhea, 52% of the patients, stomatitis, 25%, hyperglycemia, 26%. So consider that patients candidate to neoadjuvant endocrine therapy are very few, usually. Most of them, in most of the cases, are elderly patients. Would you accept this type of toxicity to increase breast conservative surgery? So this is my question. So overall, we need to wait the results of SORAL-1 and SANDPEPER, but in my opinion, PI3 kinase inhibitors, either pan or either alpha selective, maybe are not agents that are feasible to manage in the neoadjuvant setting or in the setting of early breast cancer. And now the top star of the year, the blockbusters, the CDK4/6 inhibitors. I will summarize the data in very few slides to show that we have overlap in terms of activity, just a little bit of difference in terms of toxicities. These are all the trials. Remember the population of endocrine sensitive and endocrine resistant, because here it's quite important to understand the results of this trial. So you have the PALOMA-1 and PALOMA-2 that are patients in the endocrine sensitive setting. Then you have the PALOMA-3 endocrine resistant, and again also MONARCH-2 is endocrine resistant setting, and MONARCH-3 is together with MONALEESA-2 endocrine sensitive. So let's start with endocrine sensitive disease. These are all the data. With tamoxifen you can achieve 6 months progression-free survival. With aromatase inhibitors 10 to 14 months. With fulvestrant, in endocrine sensitive, the FALCON trial, the median progression-free survival is 16 months, and including a CDK4/6 inhibitor like palbociclib, ribociclib, or abemaciclib, you may increase to 24.8 months, the progression-free survival. But if you remember in the FALCON trial, patients with bone-only and endocrine sensitive, you can increase to 22 months the progression-free survival. So the question for the future will be to which patients we can save a CDK4/6 inhibitor, because I believe there are still patients in the endocrine sensitive disease that can receive an endocrine therapy alone. So are all CDK4/6 inhibitors created equal? They are all approved, all from FDA, 2 of them from EMA. And these are the design of the trial, quite overlapping. So here, endocrine sensitive disease. So patients that relapsed 12 months after the end of adjuvant endocrine therapy. And look, PALOMA-2, MONALEESA-2, MONARCH-3, exactly the same design. Aromatase inhibitors plus or minus a CDK4/6 inhibitors. These are the results, practically overlapping. So results are consistent. You have exactly the same activity of all CDK4/6 inhibitor, either in the PALOMA-2, the MONALEESA-2, and the MONARCH-3. Same design, same results in terms of progression-free survival. Endocrine resistant disease, a different setting of patients. The design exactly the same, PALOMA-3, MONALEESA-3, MONARCH-2. We don't have data on MONALEESA-3. So fulvestrant plus or minus a CDK4/6 inhibitor and patients progressing on endocrine therapy. And these are the results. We have for PALOMA-3 a benefit in terms of progression-free survival that is quite in overlap with the Monarch 2. So, which one we have to use? Really, this is the question. And look at toxicity. Here, there is a little bit of difference. Because if you look at the data, neutropenia is quite consistent in all the type of CDK4/6 inhibitors. Here are reported toxicity grade 3 and 4. But if you look at diarrhea, diarrhea is more frequent with abemaciclib. And abemaciclib has much more on-target activity, is a better CDK4/6 inhibitor. And then the QTc prolongation is observed in some trials with ribociclib, but also in the trial with palbo plus fulvestrant. So neutropenia, fatigue, and let's say hepatic toxicity are the most frequent toxicity. In the clinical practice, these agents are very well tolerated. This is my impression. I never used abemaciclib, but I used either palbo and ribo, and are very well tolerated. So let's move now to other type of trials. This is the future. Now there is the triplet combination. There are many trials ongoing in which there is a combination of a CDK4/6 inhibitors plus a PI3 kinase inhibitor plus endocrine therapy. These are proof of concept trial. Of course, you should manage toxicity of both agents, but these studies are quite important to understand if we have to go or no go versus a triplet combination. In my opinion, are very nice study to deliver and to increase knowledge, but in clinical practice, I don't know if this type of combination are feasible or not. What about CDK4/6 inhibitor in early breast cancer? I like to mention this trial is the NEOPAL trial, presented at ESMO this year. This is a neoadjuvant trial comparing letrozole plus palbociclib versus a standard chemotherapy in luminal A and luminal B breast cancer, defined according to PAM50, not according to immunohistochemistry, but according to PAM50. And the primary endpoint of this study was residual cancer burden. And the secondary endpoint included efficacy, toxicity, and reduction of Ki67 and PEPI score. These are the patients randomized, very few patients. All of them went to breast conservative surgery. And these are the disappointing results, because residual cancer burden 0 was observed just in 3.8% of patients with the combination of letrozole and palbo, and 5.9 in the chemotherapy arm. Here I have two concerns. I would never propose a chemotherapy to a luminal A. We know that luminal A will never have a response, and I believe it's really toxic to deliver FEC followed by docetaxel in luminal A cancer. Maybe the ideal setting for this trial was the luminal B. And an ideal endpoint was Ki67 reduction, because we know already that in luminal cancers, the pathological complete response rate is very low. So it's an interesting study, proof of concept, demonstrating that the CDK4/6 inhibitors can be also integrated in the adjuvant and neoadjuvant setting. What about CDK4/6 inhibitors beyond progression? This is a very interesting trial. We performed this study in Italy. It's a trial for postmenopausal ER-positive metastatic breast cancer who received an endocrine therapy, and at progression to endocrine therapy, they have been randomized to receive palbo alone or the same endocrine therapy plus palbo. Interesting, this study. And these are the results. Look, introducing the CDK4/6 inhibitor and maintaining the same endocrine therapy may increase progression-free survival. So it seems that a CDK4/6 inhibitor can also revert resistance to that specific endocrine treatment. Which will be the future, integrating CDK4/6 inhibitors in the adjuvant setting. And here we have the PALLAS trial, that is an adjuvant trial, and the PENELOPE trial, that is a post-neoadjuvant trial, both for ER-positive and including also HER2-positive disease. And then there is also a setting of trial, the early Li1 and the early Li2, that are with ribociclib, not only with palbo, but with ribociclib. This is another pathway, FGFR pathway. I don't believe there will be a future for these agents. These are some agents for which we have already data, dovitinib, pazopanib, and then there are several fibroblast growth factor receptor selective inhibitors under development, but in other disease. Regarding breast cancer, this is the FINESSE trial, is in the context of the Breast International Group. The trial was a trial for endocrine-resistant patients, and they received the lucitanib as monotherapy. As an investigator of this trial, we stopped the trial early due to really a lot of adverse events, most of them hypertension, and we had also 2 strokes. So these type of agents are not so feasible to be managed. I believe an interesting target for the future in ER-positive is epigenetics, and BET inhibitors are quite important. I will show to you the results of this prospective randomized trial, entinostat, that is an HDAC inhibitor plus exemestane versus exemestane plus placebo. And the results of this trial are positive, finally, and there is a large prospective phase 3 trial ongoing. And many new agents under development. These are all the HDAC or BET inhibitors under development. Which will be the clinical algorithm for the future, at least in ER-positive disease? I believe that all, let's say, endocrine-sensitive disease, defined as the inclusion criteria of the trials, should receive letrozole plus or anastrozole plus a CDK4/6 inhibitor. Consider for endocrine-sensitive disease or low-volume disease also endocrine therapy alone, because you have data. In patients resistant, the combination should be fulvestrant plus CDK4/6 inhibitor, and if premenopausal, in combination with a LH analog. In case of visceral crisis, of course, you should consider chemotherapy. We don't have data on CDK4/6 inhibitors in patients with visceral crisis, but there are some trials ongoing on this. What about targeting HER2? I will provide an overview of the standard of care and then the new agents very shortly. In this slide, there is the summary of everything. So the combination of pertuzumab, trastuzumab, and docetaxel increased overall survival to 56.5 months. This is the only combination that increased survival in the metastatic setting. It's an important message. In second line, you have also an increase of overall survival with T-DM1. So first line, ER positive or negative, combination of pertuzumab, trastuzumab, and docetaxel, and in second line, T-DM1. These are the data. This is the Cleopatra, presented the first time by Baselga, and then these are the final data published by Sandra Swain on the New England, a dramatic increase in overall survival in these patients. So you should consider for any HER2-positive metastatic breast cancer patient this type of combination. These are the data of the Emilia trial, a comparison of T-DM1 versus Xeloda and lapatinib, and these are the response rate, 43% versus 30%. The duration of response is longer on T-DM1 arm with less toxicity. And these are the data, again, of overall survival. T-DM1 increased survival in second line. And this is the third line setting, the Teresa trial, comparing T-DM1 versus a therapy of physician choice. We have an increase in terms of progression-free survival again, and also in terms of overall survival, but despite in this case there is not so much difference. Which are the new agents? This is an interesting agent. This is a monoclonal antibody conjugated with the novel topoisomerase 1 inhibitor, and based on a simple phase 2 trial with 30 patients, achieving 46% response rate in patients progressing to pertuzumab, trastuzumab, and T-DM1, this agent received, a few months ago, the breakthrough designation for HER2-positive breast cancer progressing to T-DM1. It's has a very good toxicity profile. This agent is quite similar to T-DM1. The only difference is that it's binded to a topoisomerase inhibitor. It's an interesting agent. We have many trials ongoing, some of them with entire 2 antibodies. I believe I should mention the phase 3 trial that is the SOPHIA trial, comparing margetuximab plus chemio versus trastuzumab plus chemio in third-line setting. Margetuximab is a bifunctional antibody. With one arm bind HER2, with the other arm activate the immune system. And then the TULIP trial, with the new antibody conjugated versus treatment according to physician choice, like in the TERESA trial. Then we have trials with tyrosine kinase inhibitors. I like to remember the NALA trial with neratinib, and the HER2 CLIMB trial with tucatinib, that is a tyrosine kinase inhibitor selective for HER2. Then triple positive disease. This is really the future, because I am quite sure that many patients with ER positive and HER2 positive disease maybe don't need chemotherapy. So we need to develop proof of principle trials that can assess the activity of a triple combination in these patients. And here we have several phase 1 and 2 trials, including CDK4/6 inhibitors. And there is a very nice trial, prospective randomized as maintenance. Following chemotherapy, you maintain with trastuzumab plus a CDK4/6 inhibitor versus trastuzumab alone. Most of these trials are in the metastatic setting, but there are also trials in the neoadjuvant setting. And the last one, trastuzumab, pertuzumab, palbo, and fulvestrant, very expensive, but is in the neoadjuvant setting, and the primary endpoint is Ki67. And then combination with immunotherapy. I invite you to attend San Antonio in a few weeks, because will be presented the Panacea trial. It is an international breast cancer study group trial. And we take a part to this trial, and we included a lot of patients. It's for patients progressing to dual blockade, to TDM1, to capecitabine and lapatinib, and they received pembro plus trastuzumab. Patients have been stratified according to tumor infiltrating lymphocyte expression and according to PD-L1 expression that was mandatory. So all patients are PD-L1 positive. And finally, the future are the bifunctional antibodies. So this is a platform of antibody that may target HER2 with one arm, and with the other arm may activate the immune system. It's a very important concept, I believe. And this is my final slide. I believe that either in ER positive and HER2 positive, like in triple negative, we have many open questions in the metastatic disease. We need to study the so-called exceptional responders. You have some patients with metastatic disease that are long-term survivors, specifically in HER2 positive disease. We need to study the late relapses, the tumor dormancy. We have many patients in clinical practice. We need to explore chemotherapy-free regimens in the so-called triple positive disease. We need to study better lobular cancer, because lobular cancer is a different cancer with respect to a ductal cancer. We need to study better chest wall disease. We have very few trials on this type of clinical presentation. And I believe we need also better trial of surgery in metastatic breast cancer, and specifically in de novo patients. Thank you very much.